So shivering is defined as involuntary oscillatory contractions of skeletal muscles. So this is the definition of shivering. It is not voluntarily done. Patients, when what is the difference between rigor and shivering, Abhirami? See, sometimes when you start IV fluids in the ward, patients immediately after some time they say they are feeling cold and start having this sort of involuntary movements. And we say a patient has developed rigor, and we always stop the IV fluids sometime and then restart it after some time after giving some avil and other things. So is there a difference between the rigor that is developed after IV infusion and the shivering?
Yes, sir, difference, sir.
You tell me the answer before we end the class. Okay.
Yes,
So
sir.
shivering is a physiological response to cold exposure. You have the clue in this. Okay. To find out the difference between rigor and shivering. The shivering is the physiological response to cold exposure. All of us would have experienced when you go to a hill station, you don't have proper warm clothing, and you try to go out in a atmospheric temperature of 4 degrees or 5 degrees without proper warm clothing. Then all of you would have experienced shivering. So it is a physiological response to cold exposure, and it is an involuntary oscillatory muscular activity even during the early recovery of anesthesia. So when you say it is shivering, it can be a normal physiological response, or the same shivering can happen while the patient is recovering from anesthesia. So then it is called post-op shivering. And the fasciculations, you can see the fasciculations of the face, jaw, head muscle, and the hyperactivity, which last more than 15 seconds. Sometimes it will last even for uh, hours also, unless you treated early. And the patterns are two different patterns. One is called the tonic pattern, and other is called the uh, uh, which is mostly thermoregulatory, and the other is the clonic pattern. So tonic clonic, just like your seizure activity, you have a tonic pattern and a clonic pattern. In tonic pattern, it is more of stiffness, whereas in clonic, it is a jerky movement will happen. So that is the difference between the. So if you watch a patient in shivering, he will try to hold the body stiff for some time. After that, it will automatically start moving and jerking. So it will alternate with these two patterns of chronic and clonic uh, movement of the muscles. And this is because of the loss of inhibition of the spinal reflexes, usually occurring after general anesthesia. And the mechanism is the central nervous system area which is involved in this is the preoptic region of the hypothalamus, which becomes cooled. That is because the core temperature falls. Whenever the core temperature falls and there is a discrepancy between the core temperature and the peripheral temperature, surface temperature, then these problems get exaggerated. So the hypothalamus gets cooled and the efferent signals descend in the medial forebrain bundle. That is how the neurological connection happens, which comes and delivers the signals at the spinal alpha motor neurons and their actions in the final common pathway for coordinated movements and shivering. And during continued cold stimulation of skin or the spinal cord, motor neurons are recruited. So not only the normal alpha motor neurons are stimulated, but more neurons which are not involved in the stimulation are also recruited in a sequence of increasing size, starting with the small gamma motor neurons that are followed by small tonic alpha motor neurons and finally large basic alpha motor neurons. So all the motor neurons like gamma, small alpha and big large basic alpha, they all will be recruited, and that is the reason why you have a involuntary uncoordinated movements are there or oscillatory movements are happening in the muscle groups. And this is the shivering score she described is assessing the severity of shivering is called the shivering score. If the patient has no shivering, it is 0, and mild fasciculations of the face and neck muscles alone, then it is called the grade 1. And if it is seen as a visible tremor in the muscle group, it is called, that is small jerky movements of the hands and fingers, then it is called the grade 2. And grade 3 is the patient, the entire body goes into contractions and relaxations. That is the gross muscular activity involving the entire body. So there are 4 grades. Of course, grade 0 has no significance, but depending upon the severity, it can be classified into 1 to 3 mostly. And the mechanism, cold-induced thermoregulatory shivering, remains the most common cause for the etiology. And in a post-surgical patient, it can be because of the pain. Pain may mimic a shivering because patients, even when they even if they are in the normal ambient room temperature, pain will make them have this sort of dysregulated movements of the muscle, which cannot be equated to thermoregulatory. It is mainly pain induced, and it is also disinhibited spinal reflexes, and also the respiratory alkalosis. If the patient is hyperventilating, that also may induce this sort of motor activity. And the anesthetic induced thermoregulatory inhibitor abruptly dissipates, then increases the shivering threshold towards the normal. So what happens when the hypothalamus is the main center to control our temperature, and it has got a threshold value to stimulate the muscles and pass those fibers which we saw in the earlier slide to the spinal motor neurons, alpha and gamma motor neurons. And once the body temperature has inhibition has suddenly stopped, the resetting of the threshold at the hypothalamus takes some time to come back to normal, because the core temperature has to come back to normal. At that time, the shivering will continue even if the patient's surface temperature is improved. And the discrepancy between the low body temperature and the near normal threshold for the shivering is that the imbalance is one of the important reasons for the shivering. So these are the etiologies. And the, when you call a patient as hypothermic, that means the core temperature should fall down to 33 to 35. Normal body temperature, we measure only the surface temperature and say 37 to 37.5 degrees centigrade is our normal body temperature. But normally your core temperature and surface temperature are the same. That is the reason why we don't shiver normally. But when the core temperature falls to 33 to 35, then the shivering threshold is achieved, and hypothalamus starts sending the impulses to the spinal motor neurons, and that is how the shivering is initiated. And in the normal threshold is 35.5, and when it falls below that, you start getting the trigger. The anesthetic agents increase the heat response thresholds and decrease the cold response threshold, so that the normal interthreshold range is increased. That is the reason why in those days we used to say we are all called homeothermic individuals when we are conscious. That is, whatever be the ambient temperature, whether you go to a AC room or you go into the hot sun in this summer like this, our body temperature remains the same, both core temperature and but surface temperature may be slightly increased because of the exposure, but we don't we maintain the same temperature of 37 to 37.5 irrespective of the ambient temperature. On the contrary, whenever the patient loses consciousness or gets partially anesthetized even with regional techniques, we become what is called poikilothermic individuals. We are not able to maintain that same temperature all the time, and we try to take up the temperature of the ambient situation where we are. For example, if you are in a cold OT with a temperature of 16 to 18 degrees centigrade, the patient will imbibe the temperature and start losing the core temperature, and that is how the shivering will happen. And that is the reason why, whether you do a regional or a general anesthesia technique, nowadays we use all sorts of warming devices, which has become a routine affair to prevent this shivering only, because the preventing the conversion of homeothermic individual into poikilothermic and then stimulating the shivering is prevented by the mechanisms that we adopt to prevent the temperature falling down below 33 degrees centigrade. And one of the important functions of the rostral ventral medulla is to modulate the amount of pain and temperature input, so that taking proper care of pain is very important, and taking the care of the temperature by all the devices that we use. These are the two reasons why we nowadays don't see that much of post-spinal or post-anesthesia shivering happening in the current practice. And there are two types of shivering. Earlier we saw the pattern, which is clonic and clonotonic, is the pattern of muscle activity. But the two types, if you say, that has to be thermoregulatory and non-thermoregulatory. So in the thermoregulatory thing, cutaneous vasoconstriction will happen to prevent dissipation of the heat and restore the core temperature. Whereas in the non-thermoregulatory, you will find there will be vasodilatation, and that is usually because of pain. So this is how you differentiate whether the shivering is because of the loss of core temperature or reduction in the core temperature. So if the patient's periphery is cold and clammy with all the vessels constricted, it is a thermoregulatory shivering. On the contrary, if there is a vasodilatation and the patient's peripheral temperature, skin temperature looks normal, it is a non-thermoregulatory shivering, and that is possibly because of the pain. So this is the two types that we have to differentiate. So in cases of shivering due to pain, it is what we require is analgesia and not heating devices. On the contrary, if the patient has a vasoconstriction and that because that is causing the shivering, we have to treat the patient with improving the ambient temperature and covering the patient with blankets, and then using the forced air warmer to increase the temperature and bring back the core temperature to normal. So if you measure the core temperature in non-thermoregulatory shivering, it may be 37 degrees. Still the patient will have shivering because of the pain. So this is a very important differentiation that we have to understand in patients who are shivering. And the clinical importance why we have to prevent this shivering is it it causes so many changes in the body. The important function of shivering is to bring back the body's core temperature, especially in the thermoregulatory shivering. And shivering is a very uncomfortable feeling, especially if the patient, after having had a surgery, especially abdominal procedures, if they are going to shiver, it is going to cause more stress on the abdominal muscles, suture line, and it may aggravate the pain. So, and sometimes the whole sensation itself will be more painful than the surgical pain. So that is the reason why, again, we have to prevent the shivering. It increases the oxygen consumption, increases lactic acidosis because of the increase in demand. The part of the metabolism will be anaerobic metabolism, which will lead into lactic acidosis. Carbon dioxide production will be increased. So patient will start hyperventilating to eliminate this carbon dioxide, which may result in respiratory alkalosis, and that may again trigger and worsen the shivering. And it will also cause catecholamine which may be harmful to patients who have a myocardial ischemia or infarction. So it can precipitate an acute myocardial syndrome also, acute coronary syndrome also can be precipitated in elderly people with coronary artery disease. And it impedes monitoring techniques, increases the intraocular or intracranial pressures, and it is very disturbing to the mother during labor and delivery. So if a mother has to have shivering during labor, it is quite discomforting to the mother. And it increases the heat production up to 600% by to bring back the core temperature. and increases the oxygen consumption by 300 to 400%. And so demand increases, but the supply will not be there. That will lead on to hypoxemia. And it can lead to critical ischemia in the postoperative period. And with the adrenergic and the sympathetic stimulation, it can produce myocardial ischemia also in patients who are susceptible for that. And increases post-op complications like infection, pain, bleeding. And you can add wound dehiscence also to this later on because of the stress on the suture line. So delayed wound healing and increased hospital stay will happen. And it also increases the metabolic requirements, which may predispose the patient to intrapulmonary shunts, and with the fixed cardiac outputs and the limited respiratory reserve patients will be affected by that. So how to treat this? Again, as she rightly said, there are pharmacological and non-pharmacological. Non-pharmacological therapy are forced air warmers like bear hugger and other things that we use. It can be used both during intraoperative as well as for post-operative recovery time. And the mechanism is it increases the body heat content, limited the heat redistribution from core to periphery, and decreases radiant heat loss. So the three mechanisms by which this forced air warmers help are: they increase the body heat content, they limit the redistribution from core to periphery, so almost makes them balanced, and decreases the heat loss from our surface. So these are the three mechanisms by which it works. And the surface warming interferes with peripheral input from cutaneous thermoreceptors, because the once the surface becomes cold, that is the trigger to stimulate the hypothalamus, and then send all the motor response to the spinal motor neurons. So when the skin becomes normothermic or attains a normal temperature, the cutaneous afferent impulses are not there, and that is another mechanism by which it works. And passive cutaneous warming with cotton blanket and other warming devices like heated IV fluids, heated air, even bladder irrigation can be done in severe cases with warm liquids, and that is to some extent what useful, but nothing to beat this forced air warmers which are commonly used nowadays. Coming to the drug therapy, which can help in the shivering control, or very highly effective is tramadol, which is commonly available. This drug, in all my spinal cases, before washing up for spinal, I used to give 25 to 50 milligram of tramadol IV first, along with some ondansetron, because tramadol can induce vomiting in the patients. So my routine practice is to administer tramadol IV and ondansetron, which is again another drug which will prevent the shivering, and then go and wash up and give a spinal or epidural. You find the incidence of intraoperative and postoperative shivering is almost negligible. And the pethidine is another wonderful drug which will given 25 to 50 milligram IV will also prevent the occurrence of intra and post-op shivering. And physostigmine, though recommended, not commonly used. And these other NMDA receptor antagonists like ketamine and magnesium, though powerful, they have their own side effects, so not commonly used. Even though these two drugs, the commonly used clonidine, dexmedetomidine, even though books say that it is less effective, and in practice, if you see the administration of these drugs, either by IV route or intrathecally, definitely works better in controlling the shivering than the other drugs. So I also use this as an intrathecal additive to local anesthetic to prevent the shivering. And ondansetron has been also been recommended, and dexamethasone also has been recommended. So by giving these two drugs, you get an additional advantage of anti-emetic value also. So ondansetron and dexamethasone can help both with shivering as well as an anti-emetic drugs. And why treating shivering is difficult? Because it is tightly regulated by a complex multi-level control loop, including the participation of thermal receptors, spinal cord, brainstem, anterior hypothalamus, and cerebral cortex. So many components of the nervous system are involved. High nervous system, thermal receptor, spinal cord 2, brainstem 3, anterior hypothalamus 4, and cerebral cortex. So because of this complex multi-level control loop, sometimes it becomes very difficult to treat the shivering. Okay? And so that